Hi everyone, it's your friend Doris the Coder back with another video, and this video again is going to be what I promised for my anesthesiology and pain management coders. Could be acute or chronic, may largely apply to the acute setting. Today we're going to this is the part one to get unblocked with nerve blocks. So part one is going to talk about some of the guidelines, coding options, and then we'll follow up with what's next. So the purpose of this video, I forgot. If you're new to my channel, welcome to my channel. I'm Doris the Coder. And if you are coming back, thanks for coming back. So this is going to be a little longer, almost like a target practice video. It's two-part. I try to keep the videos a little shorter, so that's why I'm splitting this up into two parts. I'll try not to talk too quickly where I lose you, but also I don't want to keep you here forever. So why did I want to do this video on blocks? We are seeing a lot of changes as it relates to nerve blocks. We're seeing a lot of planar blocks, and why is that? Well, medicine is changing. As I said in my other video, which I will link here because I recorded it first, I included a really great resource that I think will help you when you're coding to kind of understand what these blocks are that we're seeing. Because medicine is changing, we're seeing more planar blocks, things like fascia iliaca and IPAC. PING, ESP, quadratus lumborum, PEX 1, PEX 2, right? And we're seeing other kind of acronyms like RAPTIR and adductor canal, and some of these blocks that's really, really making us say, do I want to be a coder anymore? I don't understand this. So if you are new to my channel, you'll learn very quickly. I am a lover of anatomy. As a non-clinical person, I don't think I can ever get enough of it just because I didn't take an 8-year. I didn't spend 8 years studying it like clinical providers do. So it's very fascinating to me. But the reason I really dig into it is because I realize this is what we're seeing in our medical records. And because that's what we see in our medical records, we have to be able to understand what we're looking at to translate and properly abstract, which might be your job as coders, or defend or educate a provider, or more so a payer who doesn't specialize in the area that we code, what we're doing and why, what is what. That's particularly important because coders and auditors that work for payers, they've got to audit all specialties that they deal with, and they don't always have the specialty experience that you might have. So why are we seeing so many planar blocks? Quite simply, the answer is that medicine is advancing and changing, and medicine always moves faster than the codes do. So that's why we're seeing, and it's not going to stop. We don't really, I think, have the best classification or kind of a consensus on guidance when it comes to some of their planar blocks. So I'm going to talk about planar blocks, non-planar blocks, and documentation issues, as well as the guidelines. So what are some of the documentation issues? Why is this complicated for us, and why is it giving us so much pause? One, because a lot of it's things that we haven't seen before, right? They're doing more planar blocks, for example, and they're using acronyms. But part of the documentation issue that doesn't really reflect or relate to our development is the providers often, when they document, I will see the approach and not the target. Non-planar blocks, things like RAPTIR, and you might see a popliteal or a subgluteal block or an axillary block. Those are typically not what they're blocking. Those are typically approaches to what they're blocking. So brachial plexus, that's where you'll see the RAPTIR, R-A-P-T-I-R. You might see interscalene or subgluteal for that as well. Axillary as well. Now, axillary is tricky because we actually have a CPT code that says axillary block. And when I educated and we audited this before, axillary nerve 64417, we have a code that says axillary nerve. And I'm just a practical person. So if I see axillary in documentation and I see axillary in CPT and they're doing a block, I'm going to probably code 64417. What you want to understand in the acute pain situation is when the purpose is to provide analgesia, that is pain relief, to a site, the axillary nerve block is not really a block you should really see in surgical. So if you see an axillary block for post-op pain, I would recommend acute post-op pain, going back to your provider and asking, is this your approach or is this your target? Because they often do an axillary approach to the brachial plexus, and let them know, listen, because you said axillary, that's what I reported. I'm an abstractor. I can't look at that and really say, oh no, the provider meant that. If that's what you meant, that's what you need to say. So recommend for your providers that they document their approach, how they localized it. They should also be able to reproduce that in the note, and the target. That will solve it when you're having a lot of the ones that relate to the brachial plexus. You might see a popliteal, for example. When they say popliteal, they're typically blocking the sciatic at the region of the popliteal, right? Because the sciatic kind of spans from like butt all the way down your leg. So they're telling you the region. But again, how are we supposed to know that? If you're not careful, that might sound like a 64450, because when I look in the book, I don't see popliteal. I wouldn't know that. Which we'll cover the guidelines in a minute. So that's part of the issue that you see in documentation. So if you have access to your providers, you can work with your providers. You need to tell them, hey, we've got to make sure your documentation matches what you do. I'm not going to sit and say, oh, well, they wouldn't do that because of whatever, and just assume, because I might be stepping outside of my role as a coder and an abstractor and getting into an interpretive level that's dangerous. So make sure your documentation matches. Now, there was a guideline change, and I think it's somewhat gray, but also a little clearer than it was before. In your 2022 book, is on page 486. Our code 64400 to 450 say 1 unit per plexus, nerve, or branch injected, regardless of the number of injections. So this is where we have to be careful, and I'll link the video to a really good resource that I posted to help you kind of get the anatomy with this. We've got to understand the anatomy to know where these nerves come off of. For years, we think, well, okay, adductor canal. That may sound like it's an unlisted block, 64450, right? Because it's adductor canal. I don't have a code that says adductor canal. When they're doing the adductor canal, they're actually typically blocking either the saphenous, and more recently with what they found after doing some dissections, either the saphenous nerve or the vastus medialis nerve. Both of those are branches of the femoral nerve, right? So I'm going to pull up this one. This is the femoral nerve, right? So this is the femoral nerve. So they don't have this kind of vastus intermedius, vastus lateralis, vastus medialis, right? If you back those up from where they're telling you those muscles where the nerves span, this actually comes off the femoral. So when we look at our guideline that tells us 1 unit per plexus, nerve, or branch, injected irrespective or regardless of the number of injections, you get 1 unit, right? As long as it's on the same side, it's 1 unit. Where we have to dig into the anatomy again, because I like to help coders find keywords. And I see femoral, and I'm like, yeah, femoral, 64447. We have a nerve. Now, notice this is just known as the femoral nerve. Well, we have another nerve that says the lateral cutaneous femoral. And this is a good depiction of it because it shows, all right, draw it back up. This is the lateral femoral cutaneous nerve. This is the femoral nerve. These are different branches. Now, so if you're coding a femoral, that's a 64447, or a saphenous or a vastus, because they're branches of it, 1 episode of 64447 per side. If they do it bilaterally, you can go ahead and report it bilaterally. But if they do a femoral and a femoral cutaneous, the femoral cutaneous is not a branch of the femoral nerve. So that is where you could have a 64447 single shot with the 64450. So be aware of that. And if it was something like the genitofemoral nerve, that's another branch altogether that's not depicted here. Again, 64450. So that's the guideline I wanted to just cover. And anytime it's very helpful to get visuals in anatomy, thank goodness, like we're coding in an age where we have, Bing or Google or YouTube and all of these online free resources where we can see where we're going and what we're doing. So once the providers get the right data there, and templating doesn't help, right? Templating was supposed to make it easier for us, and it kind of hasn't. So unless you can work with your providers and say, listen, I need 2 points in documentation. I need you to tell me where you accessed or how you approached it and what you targeted minimally. Like those are coding elements for me. I'm most concerned with what you targeted, irrespective of how you access it, because you'll notice the access or the approach isn't included in our code descriptor. The targets are, right? So providers now, from a documentation standpoint, they are not just documenting for us. They're documenting for multiple purposes. So it's a good thing that their templates include the approach, because what if a patient has some kind of complication or whatever? We've got to document well enough to reproduce the procedure to say, oh, that particular approach may cause this particular issue. So the approach is helpful clinically for reasons other than coding, but for coding purposes, you need the target. So you really have to work with your providers to find out that data and get those elements within your record so you can code them properly. So that's part. Now, planar blocks, and this is where the link to the channel that I gave you is going to be helpful. We have gotten a lot of inconsistent guidance about planar blocks. Tap blocks, rectus sheath, IPAC, SPANK, ESP, PING, PEX 1, PEX 2, quadratus lumborum, all of those are planar blocks. It seems the guidelines aren't quite clear, have not clarified for us how we pick up planar blocks. And we've gotten so many variations from CPT assistants. We have some planar blocks that are classified. For example, rectus sheath and TAP are planar blocks. Those planar blocks had unique classification in CPT with 64486 through 64489. So those are planar blocks. Well, this is something, and you can get this off the CMS schedule. I thought I opened it. No, give me a second. So this is the CMS site where you can get the source. I actually downloaded it just because it's a little easier to see. So I'm going to open it on my Excel, right? So when you are looking at these planar blocks, as of now, some of the conundrums we have, some of your codes might be classified but hidden, meaning when you see that that wrap tier, right? You don't want to code a wrap tier as 64450 or unlisted, because wrap tier is an approach to the brachial plexus. So instead, we want to go ahead and code the brachial plexus. I think that's 17. Look it up. Yep. No, that's axillary. 64415 or 6 based on whether you have a single shot or if you have a continuous catheter. So if you see a raptor, that is not an unclassified block. That is a block that's classifiable to brachial plexus because that's what they're targeting. Work with your providers on that. If you have a tap block, that's a fascial planar block that is also uniquely classified with 64487. But some of the guidance they're giving us, like the fascia iliaca, that question posed to the CPT assistant when we did, the answer they said was you use unlisted. So it kind of looks like if there's not a single target, which if you go to the coding shout out site that I sent you, if it's not a single target in those cases where they're targeting multiple nerves, they're kind of just like big spray across a bunch of nerves and dumping a bunch of anesthetic into an area that blocks multiple nerves instead of a single target. You know, some of those they've actually given us guidance to report 64999. If you are advised to report 64999, and let's be honest, when I first started my career in coding or even education and compliance, I would say if you're not sure, ask, don't guess. I've since updated to say you may not get a quick answer, and when you're doing timely filing, right, you may not get an answer fast enough to get your claim paid. Do your best, right? So figure out what the anatomy is. Maybe you use 64450 because that's what it looked like we're waiting to get guidance. So make sure you subscribe to this channel, turn on notifications, because I will be doing a video with coding guidance that's specific to some of the planar blocks. For now, we just want to say what's planar, what's not, what some of the coding issues, the documentation issues, as well as the guidelines that relate to it. So my opinion, again, has changed. I do the absolute best I can. I support what I can in documentation with whatever guidance or resources that I have, and that's where I go. But I can see that changing because, again, medicine's changing and coding is usually, honestly, years behind if we don't have people getting involved and following the right process to get the codes updated at the same time. So if you find that you're doing like a fascia iliaca or a ping or one of those ones that they've given you a 64999 with. 64999 is an unspecified code. You won't see it here because it has no value, so it has no work RVUs. But you want to find out where it is and notice. So when I look at work RVUs for these different nerves, the work is different because work factors how complicated or technically difficult that procedure is. You also will have a section under here for MP malpractice, right? And it's weird because even though the work is different, it seems the malpractice is kind of very consistent throughout these. I see a lot of 11s and 17s, but for some of them, again, they are a little bit higher, like this one that has 0.17. But look at the work RVUs when you are looking to price your unlisted code. The mistake that's made before, especially if you don't have access to a provider to have a dialogue to find out the anatomy and the complications with doing the procedures, you might price them at 64450. Well, 64450 has 0.75 RVUs. And let's be clear, I don't make recommendations based on value alone, but I understand when codes are valued, things like risk and complexity and technical difficulty of doing the procedure factors. So that's why I look to the value. When we look at 64450, it's one of probably the lower value codes at 0.75, right? So when you do an unlisted code 64999 and you price it to 64450, you're probably undervaluing your provider's work. Instead, what I'd recommend you do is look at where those nerves might be, right? Where do they come off of? What nerves around it? Because you'll see those values change based on where you're going. The brachial plexus, for example, even the axillary, right? Because there's structures they've got to worry about, especially when they're around this area. You might numb the patient from like eyebrow down. In some of the lower extremity procedures, if they hit the wrong thing, they can actually cause foot drop in a patient. So those kind of risks are factored. So look to the anatomy by site. And what I often do for my providers with unlisted procedures, and I have access to my provider, so I can actually dialogue with my providers, but I ask them, okay, I need you to compare the work for me, right? Not the code, compare the work for an established procedure that we have. So it's kind of in the hip, or it's kind of in the lower extremity. Is it more like the risk associated with doing a femoral, or more like a sciatic, or more like something in the hip? Like tell me, give me my rationale for that. And then when I send the unlisted code, I'll reference that similar procedure. My provider will also tell me how much more, how much less complicated it is to the reference procedure. And that's a better value. That's really all we can do right now until we get some clear answers. So if you want to stand by, I think it's good to turn on subscriptions. My next video is actually going to have some of those answers to give you guidance on what you would do from a code perspective. So when you see those new acronyms in your chart, make sure you research them. Some of them, like PING and SPANK and IPAC, they are acronyms for planar blocks. Others are acronyms for branches or divisions of nerves that we already have codes for. Never, ever mind researching, right? Look up a visual, figure out where that structure is. Don't get stuck on words like femoral and axillary and code those wrong, because remember what I showed you with the lateral cutaneous femoral nerve versus the femoral. It might look like it's one on the same side, but it's not from the same branch. And it helps to kind of trace it back and research it. So stay tuned for my next video. If you have any questions, comments, you know what I say, like it if you do, share it, So if you think the information is helpful and would benefit someone else, and subscribe if you want to stay on top of what I'm doing timely with regard to these things. I'll definitely be following and reporting as often as I can. It'd be great if I could post like every week, but like I don't have that kind of life, to tell the truth. I can't do that. But I post as often as I can, share sources with you as much as possible. And until the next video, I'm Doris the Coder signing out, and I will see you then.